Hello everyone, my name is Charlotte and I am presenting this poster on behalf of my team at Crit Psychology. This poster is an examination of internalizing and ADHD symptoms in PCIT baseline assessments. We know PCIT to be an empirically supported treatment for young children with externalizing symptoms, as well as having successful adaptations for other populations, such as social anxiety in PCIT-CALM and selective mutism in PCIT-SM. While many families seek treatment due to their child's disruptive behavior, clinicians commonly note high comorbidity of internalizing symptoms, such as anxiety, excessive worry, and difficulty with separation. The ECB, however, fails to capture internalizing symptoms. Most importantly, we understand that failure to assess for internalizing symptoms could interfere with PCIT progress if not accounted for. The purpose of this study, it was to examine the relationship of baseline scores on 3 measures screening for internalizing and externalizing symptomology in families presenting to our practice to understand the baseline comorbidities in these children. These comorbidities, we expect, could warrant significant tailoring of treatment or additional treatment to address them. In this sample, we had 42 families with children between the ages of 2 and 7 presenting to our private practice setting in New York who were recommended PCIT. The families needed to complete all 3 of the measures below at baseline to be included in the study. The measures we used are all based on parental perception. The ECB looked at the frequency and level of concern of disruptive behaviors. This is the measure used in the PCIT protocol. We also looked at the SNAP, which measures the parental perceptions of externalizing symptomology of ADHD and ODD symptoms, as well as the SCARED, which is the screening measure of parental perceptions of the internalizing symptomology across 5 common anxiety domains. These are social anxiety, generalized anxiety disorder, separation anxiety disorder, panic disorder, and school avoidance behaviors. The SNAP and the SCARED are also in the public domain. The measures were administered at intake or at the DPICS baseline observation task session used in PCIT protocol, and descriptive statistics of the baseline scores were analyzed to determine the frequency of clinically significant scores across the sample. In our results, you'll see the table which lays out the 3 measures, the categories, and the percent of the sample size in the clinical range for each of the measures. In our sample, 68% exceeded 1 standard deviation for both intensity and problem score on the ECB, which for our purposes we are indicating as the clinical cutoff. 29% of that sample that exceeded clinical cutoff on the ECB also exceeded clinical cutoff on the SCARED total score. So parents reported high frequency of internalizing symptoms. That's nearly a third of the kids with a clinically significant ECB also featuring high internalizing symptomology. 57% exceeded clinical cutoff for hyperactivity and impulsivity symptomology as captured on the SNAP. These figures on the next slide highlight the overlap a bit further for all of you visual learners. And they're not scaled to measure, but if you can see how in figure 1, you'll see the overlap of the clinical versus subclinical ECB population and the clinical SCARED subcategories. So you'll see how in our clinical ECB population, 29% of them also met criteria for clinical criteria on the SCARED for any category, and that was 54% for the non-clinical ECBs. So again, these are all children who were recommended for PCIT treatment by the clinician once they presented at intake in our office. And you see this great comorbidity, this overlap of internalizing and externalizing symptomology as captured in the ECB and the SCARED. In figure 3, you'll see those subscales of the SCARED broken down even further. Notably, social anxiety and separation anxiety were pretty present in our population. That's 22% each Of the total population that met clinical criteria on the SCARED, what that was the subscale that was most common. Next, you'll see generalized anxiety disorder and school avoidance, and then a bit of panic disorder. In figure 2, we are looking at the comparison of the SNAP subscales to the clinical ECB population. And again, you see this great overlap, not surprisingly, of ODD symptoms and a clinical ECB score, that's that 79%. But you also see this 57% of the population who had a clinical ECB score also met clinical cutoffs for hyperactivity and impulsivity symptoms in the SNAP. So you're getting a lot of information about what these parents are reporting that they're seeing in their children just at baseline. In figure 4, this is a model that Dr. Kurtz loves to use when describing treatment progress with comorbid disorders. You are identifying your primary and your secondary diagnosis, and what you're going to see is high impairment of both diagnoses at the beginning of treatment, and over the course of treatment, you might tend to one, so you might tend to the primary diagnosis first, and then you'll see that drop in terms of clinically impairing symptoms. And then what you might see are a few different results. You might see the secondary diagnosis also drop without even primarily treating it. You might see that stay the same, and then that's when you would switch over the course of treatment, tailor, do what you need to do to address those symptoms, and also hopefully see that go down, and you have this kind of parallelogram effect. So at its core, PCIT emphasizes relationship building and provides a strong foundation of skills, allowing for its implementation across various clinical presentations. As I noted in the beginning, 68% of our population met clinical cutoff for the ECB, and conservatively, for those 32% remaining, you might exclude them or not consider them for PCIT, but we thought that those families could still really benefit from the skill due to their presentation. The sample demonstrated high co-occurrence of internalizing symptoms. As we hypothesized, approximately 1 in 3 families met clinical criteria on at least one SCARED subscale. But really, routine screening of internalizing symptomology is crucial to gain insight into the function of the observed behaviors. That way, you allow the possibility that the behaviors in question could serve other purposes. This facilitates a holistic understanding of the case to better understand and inform the sequencing of treatment and ongoing assessment. You're really wanting to capture and completely understand all of the different possibilities in your case, how these children are presenting at intake at baseline. And so what we were really looking at is capturing that full clinical picture using these measures. Some limitations were that data was collected in a private practice. Therefore, the results are not necessarily generalizable. We would like to expand the study, include different settings, and see what those results in those cases might look like. Parent report also of child anxiety and behaviors are difficult to validate. All of the measures that we used were parent perceptions, parent reports. This might be an interesting study to look at, validated with a diagnostic interview. And for future directions, you'll really want to expand on the baseline data and capture the progression of the internalizing and externalizing symptomology, and really see, as highlighted by that last parallelogram figure, what does this look like in treatment, and how can clinicians best support these families who are presenting with different, slightly more complicated cases. On the next slide, you will see our references, and this is the full poster. Thank you for watching my presentation.